Hello, my name is Christina, and I'd like to welcome you to my Change Quality Project for Nursing 451 Leadership and Management. At my place of employment, there has been an ongoing issue with community-acquired pressure ulcers, which is a preventable issue. In the following slides, I will discuss the quality improvement and changes that were made to improve patient care and prevent future community-acquired pressure ulcers. This is the quality improvement cycle. This quality improvement cycle is intended to help nurses and healthcare providers give better healthcare for their patients by preventing pressure ulcers using this model. The goals of the quality improvement cycle begins with a plan, which is intended to set goals and data collection, which is the who, what, when, and where of the project. The D stands for testing the plan and documenting the plan. The S stands for study, for completing data analysis and deciding on the action. The A is for acting, which includes implementing the actions. I am employed at Elite Care Management Home Healthcare. And in the home care setting, pressure ulcers are often overlooked until it's too late. These patients were admitted to the hospital, or some of our patients were admitted to the hospital for stage 5 pressure ulcers or related complications. The ulcers were acquired at home or some from independent and assisted living facilities, which we also visit. Identifying the patients at risk is key to preventing pressure ulcers through education. A pressure ulcer is a localized injury to the skin and underlying tissue, which is usually over a bony prominence. Pressure ulcers are chronic wounds with physiologically impaired healing. Pressure ulcers are a pandemic among bedbound populations, with a reported amount of 39% coming from nursing homes and home care patients. These estimates likely underestimate the true scope of the pressure ulcer pandemic, as many cases are underreported due to concern that a pressure ulcer may be interpreted as a neglect issue. Every year, billions of dollars are spent on the treatment of pressure ulcers and associated morbidities, which is representing a significant portion of healthcare resources. This figure will continue to rise over the next decade. Appropriate cost-effective treatment modalities are therefore of the utmost importance. Emphasis must be placed not on decreasing incidence, but on early treatment of pressure ulcers in order to minimize costs, comorbidities, and ensuing costs. Okay. Despite growing resources invested into the development and implementation of evidence-based prevention protocols, research data demonstrates that the rates of community-acquired pressure ulcers are still high in many areas across the globe, as well as in my very own place of work. For high-risk populations, such as older people or critically ill patients, a cumulative incidence of 15% or higher continues to be reported with respect to pressure. To improve preventative care and home care practice, it's important to advance our understanding of the mechanisms behind implementation strategies. This includes regular skin assessment should be performed to identify the early stages of damage and prevent more severe stages of pressure ulceration. Early identification can target equipment appropriately, potentially result in cost savings. Maintaining healthy skin can also help reduce the likelihood of skin breakdown, which incurs significant costs with dressings, equipment, and staff time. It is also detrimental to patients' well-being and increases the risk of development of infection. So here's the standard. It's comprehensive skin assessment, standardized pressure ulcer risk assessment, nutrition assessment, and care planning and implementation to address areas at risk. The evidence is a decrease in community-acquired pressure ulcers, reduction in patient morbidity and hospitalization, and also improvement of patients' quality of life. Okay, the development of community-acquired pressure ulcers begins with both a financial impact to an institution or performance of quality care of impact that can affect the quality of the patient's life. The expectation that is expected is that the patient population at risk will properly be assessed. It was found that patients were not being properly assessed for pressure ulcer risk in order to use preventive measures such as education. One, we are accountable for pressure ulcers because they're completely preventable. The issues come from improper assessment and lack of patient education. After reviewing patients who are being treated for pressure ulcers, it was found that 10% of the patients being treated were treated for pressure ulcers. Ideally, there should be 0% of pressure ulcers since it's preventable. The goal is to reduce pressure ulcers by at the least 50%. Some of the root causes were The main ones were poor identification of patients at risk, the lack of education, and lack of communication and charting of evidence. Here is a chart that shows the risk of pressure ulcer by the number of risk factors present. So if a patient has, here has the numbers 1, 2, 3, 4, 5, 6, 7, 8. Those represent how many risk factors. So if a patient has 8 risk factors, which I'll describe, more than 20% of our patients will end up with a pressure ulcer. These 8 major factors includes age, lack of mobility, poor diet, unwanted moisture, pressure ulcers in the past, mental and neurological and other physical problems, friction and shearing, wrinkled sheets of hard objects left in bed. Consider other risk factors that are present, such as shortness of breath, weight loss, inability to eat, surgery, diabetes. Consider if the patient cannot move voluntarily, if they're bedridden, chair-ridden, are they high risk? We also need to look at age, which I think I mentioned. Urinary catheters are also another cause. NG tubes, oxygen cannulas, oxygen masks, lack of staffing. Mostly, I've listed a lot of the equipment that's left on too long also causes pressure ulcers. We want to use valid, reliable, and age-appropriate method of risk assessment that ensures systematic evaluation of individual risk factors. We need to assess all patients at the time of getting a new patient, at regular intervals, and after to see if there's any change of conditions. A schedule is helpful and should be based on the individual acuity of our patients. Next slide. Scope of the problem. So the stakeholders is who is affected. That's the patients, healthcare providers, insurance, and Medicare. Pressure ulcers are one of the major issues associated with service quality and patient safety. Pressure ulcers occur in patients of all ages in various healthcare settings. Prevention of pressure ulcers is not only an indicator of the quality of care, but also has a significant impact on residents, care staff, and healthcare costs. Pressure ulcers have been rated the 5th most frequent cause of potentially avoidable hospitalizations. Pressure ulcers cost between 9.1 to 11.6 billion per year, and the use and the cost of individual patient ranges from 20,000 to 151,000 per pressure ulcer. Medicare has estimated that each pressure ulcer will add 43,000 per cost per patient. Preventing pressure ulcers in the home setting will also prevent unnecessary costs, which is hospitalization. Okay, solutions. We want to involve patients and family in pressure ulcer prevention at the earliest opportunities. We want to develop a contract of care. What can we do together to help prevent pressure ulcers? Providing the patient with information leaflets can help, and the most important is consider risk factors that are currently present. So we could use individual risk identification and risk assessment tools such as the chart mentioned earlier. Okay, so the analysis. Challenges and risk factors were identified that increase the likelihood of a pressure ulcer. We compared the previous status and the current status of the shifting dynamics of pressure ulcer policies. The data collection includes whether or not staff used education pamphlets, used a score chart, assess the role of existing and potential financial incentives and quality initiatives, improving the outcomes of care. We shared with staff members the results from the data collection and then regrouped with staff members to address any new concerns. What are the next steps? Okay, the next steps will include, for home care, we'll assess on admission and at every nursing visit. Measures in place based on the analysis of the effectiveness of change will stay up to date with current policies, procedures, and studies. We'll continue staff education at least twice per year and follow up with annual competencies for all staff members. If the goal was not met and the program was unsuccessful, we will reevaluate all data and edit accordingly. And here are my references.